to start with a patient who has actively trying to conceive. She has a history of PCOS and irregular cycles. And so before we jump into this patient scenario, I'd love to ask Dr. Stefani here, what are some of the challenges of monitoring and assisting women with PCOS?
PCOS is complicated as a hormonal condition, whether or not individuals are trying for pregnancy. And what's tricky about it in terms of monitoring with different kinds of qualitative measures
Mm.
is that oftentimes, from a hormonal perspective, individuals with PCOS can have continuously high LH or continuously low LH. And so those don't get captured with typical methods. And they often have really delayed ovulations or have really suboptimal or
Mm.
anovulatory cycles. And so having one way to quantitatively be able to literally see if they have a little low LH spike or if they're higher, but then their set point is high and it can just go a little higher as their trigger. And then seeing if they did ovulate or didn't in that cycle, that's really helpful as there are so many different subtypes of PCOS. And as a provider, looking at the symptomatology, we could theoretically just be throwing a lot of different medications or supplements at them and to really understand their symptomatology from a hormone standpoint and literally be able to see cycle to cycle if they're improving based on the changes that you made, then you can really empower the patient and feel empowered yourself of knowing what is and isn't working to support this patient with regulating their cycles, improving their ovulations, improving their FSH LH ratio, things like that.
That's wonderful. So let's jump into this first patient scenario. So she is a 26 female. She's been trying to conceive for 1 year without success. She was diagnosed with PCOS at age 18. And she had said she had irregular cycles ranging from 31 to 52 days. About a year ago, she had noticed her cycles had become more regulated, but unfortunately, more recently, they were irregular again. So she began testing with Mira, and you can see the Mira data discovered an ovulatory cycle. She had an LH surge on cycle day 18 through 20, and we see the PDG changes confirming ovulation. But if you look closely, she has an abnormality in her estrogen or her E3G pattern. We see that her estrogen is higher in her luteal phase than her follicular phase. So, from my standpoint, we're starting to see a little bit of a warning sign. So, her follow up Mira data now shows a non ovulatory LH surge or failed ovulation attempt. And we can see that because if you look very closely, it looked like it was going to be a very good ovulation coordinated E3G leading to her LH surge on cycle day 17 and 18. But there was that lack of coordination between LH and FSH. So FSH barely changed. So thankfully, the patient continued testing, and you can see her PDG levels did not significantly rise. And the patient went on to have another LH surge to trigger ovulation. And we can see this second LH surge was successful because we see the rise in her progesterone afterwards. So, from a clinician standpoint, how would this information be helpful for you when you're getting started with this patient?
I think it really is helpful because right away you can have a better understanding of their hormonal patterns. And we can access some of this for sure with blood labs of hormones, but they're one time snapshot and with Dutch and other things that are looking at the metabolites. But to be able to have a cycle by cycle changing pattern to see what are the things that you need to focus on as a provider and to help the patient understand and be empowered about her cycle, whether she's using this information to try and conceive or to try and avoid conceptions, be really helpful because just from a symptomatology standpoint, especially like with this double attempt at ovulation, she could be having cervical mucus changes throughout those whole from a few days before that first attempt, that first little LH spike to that second one. And the first graph that you showed it's really common with PCOS that they struggle with uterine lining concerns. And so it's not just about, we talk a
Mhm.
lot about the ovulatory concerns, but then there's also the uterine concerns. And if you don't have good estrogen support in that follicular phase, then from the uterine perspective, you're not getting this proliferation of the lining. So even if she has a ovulation that could be compatible with a pregnancy, the uterus might not be ready to receive that pregnancy. And if she's not trying to get pregnant, that matters too, because the sort of chronic lack of progesterone support and lack of proliferation in the uterus is dangerous for the uterus over the long term. And so it's really good from a current standpoint. What are
Mhm.
they doing well with? Where do you focus your treatments? And then see what's working, what's not working. See that those ovulatory attempts come together, either with the feminescence maca or with melatonin or with Clomid or letrozole, and see how she's doing from her symptom standpoint so she can be really empowered in this process and you can feel like you're more efficient in the process.
Mm. I think too, if I was the patient, I would be very confused at if I thought I ovulated on cycle day 17 and then you proceed to go on for, let's say, 20 days without a positive pregnancy test or no period coming. I can see how that would be very frustrating from the patient's side as well. So not only can the provider be more effective, but the patient can have much better understanding as well.
Absolutely, absolutely. And that mental health piece is
Mm,
huge.
yes.